Everyone's attention. We'll see if this works. So look, I'm just going to give a little bit of an update on prosthetic joint infections rather than an overall all-encompassing lecture, but it will cover a lot of the important topical things at present. I mean, we all know that this is an important topic because 40,000 hips and 40,000 knees are done in Australia now each year, and if you assume a rate of infection of 1%, that's an enormous workload of 800 new deep infections every year spread around the country, and economy, that is a significant impost. If each case costs $100,000, and that's probably conservative to treat, then $80 million each year added to health. I'm going to talk on what I think is important just at present, which is the diagnosis of prosthetic joint infections. Talk a little bit about antibiotic beads and spacers, some of the principles of prosthesis retention, which is topical at present in the treatment of deep infections, and two-stage revision, which is really the workhorse for management of deep joint infections. Now, all of us know that the diagnosis is not always straightforward, nor is it easy, and we're considering the diagnosis of a deep infection of the hip and the knee in the situation of a patient presenting with a painful joint replacement, and that may be any time after the index surgery or when working a patient up for revision of a knee or a hip replacement. They're the two settings that we're considering. You want to all have a look at this document. The American Academy of Orthopaedic Surgeons has produced a practice guideline on the diagnosis of prosthetic joint infections of the hip and knee. Has anyone here seen it or aware of it? Yeah? Is everyone aware of it? Yeah, good. It was released last year, and it's pretty clear on what's evidence-based and what's consensus recommendations, and there's a bit of each in it. And similar to Australia, America has quite a large workload managing these joint infections. So there is more and more surgeons are getting involved in the management of deep infections, and the Academy has identified that simply the diagnosis as an area which requires a lot more, the surgeons require a lot more guidance and help. So some of these principles and consensus. Investigation of a suspected infection should be based on stratification of risk. That sounds obvious, but you don't do everything for every patient. You target those that have a high probability of prosthetic joint infections, and this is based on symptoms, risk factors, and the physical examination. You're all familiar with what those risk factors might be. Anything that creates immune deficiency, diabetes, rheumatoid arthritis, etc., etc. So you stratify your investigations. They recommend that ESR and CRP, both of them, should be the starting point of investigation because of the very high positive likelihood ratio. In the setting of a painful joint or a joint that's failed, considering revision, aspirate those with abnormal inflammatory markers. Send that synovial fluid off for both microbial culture, but also a white cell count. and they specify a white cell count of more than 1,700 white cells per microliter as being positive, and translated in litres, which per litre, which is what we usually get, and a differential white cell count of more than 65%. It's important that the aspiration be performed off antibiotics, not just for a few days or a few hours, but for 2 weeks pre-aspiration in an elective situation, and then re-aspirate with a negative culture goes against what you suspect clinically. Acute infections, it's not clear yet what the white cell count thresholds should be, and there's a little bit of data from Baltimore, but the Academy, they couldn't agree on that, and there really isn't a lot of evidence just yet. Moving on to imaging, I guess the recommendations were to consider nuclear imaging when the diagnosis wasn't established, but there's a high probability, clinically, a high ESR, or with inconclusive aspirates. Most of us don't find nuclear imaging that helpful, but there was an opinion rather than evidence that a CT and MRI role is certainly unclear in diagnosis. You see osteomyelitis, then you usually see that on a plain X-ray, but a CT scan or something. Well, periostal new bone formation or lysis, flaky, abscesses, see all those on a CT, but usually they're very late. I still hear of intraoperative gram stains being performed, and there certainly is a very strong recommendation against intraoperative gram stains. Very unreliable. And there's a recommendation to use frozen sections when reoperating in the revision situation, that is, and the diagnosis of a joint infection is not established. So this is really in pretty much every revision joint replacement. Good rule-in test has a low value in ruling out infection. I personally feel that you've got to have a pathologist who's happy to look at frozen sections, but there's certainly a lot of evidence that they can be helpful, and if you have a pathologist who can do it, then certainly very helpful as a rule-in test. Time of revision surgery, as we all know, you've got to take multiple cultures, 5 or more. Other strong recommendations: do not commence antibiotics in patients with suspected joint infection until after cultures are obtained from the joint. And that's something that we all know that still has to be drummed into all levels in our hospital, from the emergency department up. So the false negative rate is 55% if they receive antibiotics, whereas it's certainly not a perfect test if they haven't been on antibiotics, but 3% false negative. If you are revising a joint replacement and do not suspect infection, then the recommendation is not to withhold prophylactic antibiotics until cultures are obtained, and that's been my practice for many years now. I think if there is a deep infection, you'll diagnose it even in the presence of prophylactic antibiotics, and there's evidence for that. There was some information presented at the Academy in February which I thought was really helpful. Javed Parvizi from the Brooklyn Institute, his group there has done a lot of work on synovial fluid from hip replacements and knee replacements, and he was presenting some conclusions in both hips and knees. And it turns out that the CRP on synovial fluid is very sensitive and highly specific for infection. And they were using ELISA and multiplex assay, but they're now starting to use your normal laboratory serum assays. They haven't been fully validated yet, but that's something that's going to be helpful in the future. And they looked at other cytokines, and IL-6 is going to be helpful. PCR on aspirate is available now, and that turned out to be very sensitive and specific. RNA PCR for the common bacteria. Pointed out to me, and we've started using urine dipsticks on synovial fluid. So you look for neutrophils, and there is there's a square on the urine test for neutrophils, and 2+ in synovial fluid is 100% sensitive and 80% specific. We recently had a woman who presented with a septicemia. She had rheumatoid arthritis, a septicemia. She's got bilateral revision hip replacements, bilateral revision knee replacements, and 3 joints were 24 hours after the septicemia, painful and swollen, and we aspirated all 4 joints, and 3 out of the 4 were positive for and were confirmed by culture. In acute infections, they've suggested, this is at Rothman, it hasn't really been universally accepted yet, but certainly a higher white cell count and 27,000 per microliter equals infection, and slightly higher percentage of one thing, we're all aware that Staph aureus or infections can recur many years after a previous deep infection, and it was news to me that these organisms can become dormant and intracellular in periprosthetic tissues, and this may explain why. So everyone should have in their head a set of diagnostic criteria. What equals a deep infection? The Rothman, they've suggested that anyone who has a positive culture has a deep infection. Anyone who has purulence found at surgery. Anyone who has a draining sinus has deep infection. And then anyone who has 3 of the following, either a raised ESR, a raised CRP, a raised white cell count in the synovial fluid, differential white cell count in the synovial fluid, 73% for chronic infection equals a deep infection. So these are helpful in answering the question, is there an infection or is there isn't, which you think would be a simple question, but is actually one that we struggle with a lot. Is there an infection or not? Are there any questions regarding all that before we go on? Before, but we struggle with this every day of the week. Every week of the year, I'm struggling with a lot of these